Hello, this is Dr. Rutledge, and there was some questions that came up on the Facebook page today. So I thought I'd do a little commentary on my slides series on the twisted pouch. So I'm going to share my screen and we'll talk about the twisted pouch. Okay, and let's share my mouse. Okay, so we're going to talk about technical errors, mostly the twisted pouch today, but also some other things. How you can make a twisted pouch by doing an anterior Gastro-Jejunostomy, things like that. And that came up on our discussion group today, so we'll comment on that. Okay, diet and marginal ulcers, H. pylori management. There's a whole bunch of other things to talk about as far as the management of postoperative MGB, postoperative sleeve and postoperative Roux-en-Y, reflux disease, and marginal ulcers that I find, at least in my humble opinion, there's a lot of misunderstanding, mismanagement, and patient suffering that goes on because of misunderstanding on these topics, but we're going to focus on something else. And this is one of the things is marginal ulcer in MGB and Roux-en-Y is why do they happen? Why is it always at the margin? Not always, but mostly. Occasionally you'll find it in the jejunal area, and why would it be there? And but acid is everywhere, and acid, particularly in the MGB on endoscopy or on acid testing in the stomach remnant, hits pretty neutral area. And so you hear a lot of people talking about PPIs and things like that. So the simple thing that I'm saying that I see is basically it's blood supply or ischemia is a primary misunderstood, mismanaged, and unrecognized variable. So a PPI in somebody who's getting, I mean, the gastric pH in somebody who's getting PPIs is usually greater than 6. And what causes marginal ulcer? We were on a conference call on this not long ago, and people were saying acid, and one surgeon was saying he did truncal vagotomies. And so we're not going to talk too much about that today, but I think that's a mistake. And basically PPIs and marginal ulcers, the gastric pH in a PPI stomach is already neutral. So they're hypochlorhydric. And so a single dose of PPI decreases the pH acid 10,000-fold from a pH of 2 to up to 6. And so why they're worried about acid, I think, is a misunderstanding. And particularly like in a Roux-en-Y where there's hardly any gastric parietal cell tissue left, why marginal ulcers highest soon after surgery and a time of greatest ischemia and prior to the growth of new blood supply. So the other thing we notice is some surgeons seem to have a lot of marginal ulcers and others seem to have a low rate. Well, it's possible that it's just a poor quality reporting in one group and excellent quality reporting in the others. But it's also possible, and in my opinion, the accurate answer is it's a technique. That is, the technique affects the blood supply and it's not acid, it's ischemia. So anyways, now let's see if we can explain why this happens. So this is a gastric pouch. Now, it could be a Roux-en-Y, could be MGB, could be one of the other distal bypasses. But basically, after we create this pouch, there's only going to be one source of blood supply. That's in this lesser curvature of the stomach. Then we have a staple line at the base and a staple line laterally. This we're going to call the neo-greater curvature. All right. Now, that means the only way to get blood out here is it has to come from medial. This seems obvious, but it seems like a lot of our surgeons seem to miss it. Now, let's imagine that you go out here and put a staple line out here and a staple line here. That means almost no way that this tissue in here is going to get any blood supply. All right. What we think is if you move this staple line here more medially, then you have more chance of collateral blood supply through the very vascular stomach. And that's what we suggest is you pay attention to this issue. So if you put the staple line here, we call this a bad or an ischemic Gastro-Jejunostomy staple line. If your Gastro-Jejunostomy lateral staple line is close to this staple line, we think you have the risk of stricture from ischemia. Also, you have a lot of staples, foreign body, and that leads to ulcer, gastritis, and bile reflux symptomatology. Bile reflux into the stomach is normal every day for every person on earth. it becomes a danger when the bile stays in the area or there is a at-risk mucosa. Well, this creates at-risk mucosa. On the other hand, moving here means that you can have collateralization through the network of blood vessels that are on the perivascular stomach. Okay, the next thing we're going to talk about is the twisted pouch, and this is a common error in what my experience of new and inexperienced MGB surgeons. It's common in Roux-en-Y surgeons who are constantly trying to make a small, narrow, obstructive Roux-en-Y pouch. It also happens commonly in my experience when they have a low port site. So then they twist the pouch because of poor positioning of the first staple cartridge. And we'll look a little bit of that. And that begins the twist, and we'll show you some videos. The second common error is a short posterior pouch wall. So that is, if you think of the ideal posterior pouch wall, it would be basically at exactly 180 degrees from the lesser curvature. On the other hand, if as you put the staple gun in, instead of stapling exactly perpendicular to the anterior posterior surface, you make it gradually narrowing the posterior wall, then you're going to get the attention of a spiral pouch. And as that pouch spirals, that twist makes things worse for the complications we're going to talk about. So these two errors, twists of the anterior pouch surface, twists 180 degrees, and this makes the anterior GJ seem like a good idea. That, in my opinion, is wrong. It's a technical error, which leads to complications in our patients. In my opinion, the anterior gastro-jejunostomy only looks like a good idea because the pouch has been twisted. And we'll see some videos and slides and photographs of this. When the anterior surface appears to be in a good location for the gastro-jejunostomy, it means you've created a twisted pouch. And this results in postoperative nausea and vomiting, a relative obstruction to the outflow of the stomach, and short and long-term dyspepsia, dysphagia. The stomach pouch untwists the twisted bowel loop, okay? Now, how should the tip of the gastro-jejunostomy look, and how should the gastric pouch look? This is my opinion of an almost ideal gastric pouch. Here we see the lesser curvature is in the position of the lesser curvature, and the neo-greater curvature is in the same plane, according to the yellow line here, as the greater curvature normally is. So this is the way we would like to see it. On the other hand, this is not the way we want to see it. So we have this tip, which should be the lesser curvature, and these vessels have been turned and torqued all the way around, almost a 360 degree, well, 180 degree twist. So this tip here should go all the way back here, but instead this is twisted around. Now you can see the anterior surface looks like a good place to put the gastro-jejunostomy. This is a 180 degree twist. The 9 o'clock position of the stomach, the lesser curvature, has twisted around to the 3 o'clock position. That's wrong and should be obvious, but we see people do this all the time, and somehow they go on big meetings and they say anterior gastro-jejunostomy in an MGB is a good idea, and they're surprised when they have a lot of marginal ulcers and gastritis, nausea and vomiting, bile reflux. Again, this is not like a normal stomach. I shouldn't laugh because it's terrible, but okay, here's an extreme example where the whole gastro-jejunostomy is completely twisted around. So this was done over here, and of course the stomach snapped back, and now you get an obstruction. Let me say this again. When this was done, this staple line was over here, right? It looked good because it was a twisted stomach, and then it untwisted, and now look at this, all right? This is a nightmare. This is a technical error. It's not a complication of MGB. It's a complication of the surgeon who performed the MGB. Now, I happen to know this surgeon. That surgeon is a wonderful surgeon, and not to criticize that person. Anybody can make a mistake, but we have a lot of people who are intentionally making this mistake. Again, here it is, totally wrong. See what's happening here? Look, here's the tip. This should be here, and instead, we're going to do this gastro-jejunostomy here. This will tend to turn this over, and of course, like the other X-ray, the other photograph we just saw, it's not unreasonable. This stomach might try to twist back, and then you'll see this reversed and flopped on itself. This is an error. It's a twisted pouch. This causes bile reflux. This causes gastric outlet obstruction. This is a technical error, which a lot of surgeons perform. And then they say, look, this is a good idea. Now, another thing that's narrow, that's kind of subtle is look at this staple line here. Here's the gastrotomy, and here's another staple line. So that means there's going to be a bridge of tissue between this gastrotomy and this staple line. That's all going to die because there's no blood supply there. So the way this staple line is being done, so the staple gun is from the wrong angle, the gastric pouch is twisted, there's going to be a relative outlet obstruction, and they're going to leave intentionally dead tissue and foreign body at the Gastro-Jejunostomy. So it's 100% wrong. It's not an MGB, yet he will claim that this is an MGB. He'll say it's an MGB, and if it has reflux, they'll say, look, MGB has reflux. No, the surgeon caused reflux. So same thing again, and we'll stop this pretty soon. So neogastric pouch should not be twisted. That should be obvious. The lesser curvature should lie at 9 o'clock medially, and the neo-greater curvature should lie at 3 o'clock on the face of a clock. Twisted or a wrong pouch makes the anterior GJ look good. If you think the anterior GJ looks good in your MGB, you've done a wrong, biased, damaged, mistaken, harmful operation. I wish you wouldn't call it an MGB. Call it by your own name. Don't call it an MGB. You're hurting me. You're hurting other patients. You've hurt that patient. Understand this error before you start doing MGB. The twisted gastric pouch syndrome, post-op nausea, vomiting, CT scan, and endoscopy is frequently negative, and you have invisible illness. You have to revise the patient, and the prevention is simple. Just don't twist the pouch and never do an anterior anastomosis. I think I might have been a little harsh. My apologies.